Hello everybody. Welcome tonight to the next session of the Virtual Global Spine Conference. I'm beyond thrilled to introduce my friend and colleague, Dr. Catrina Scherrer,
Hey.
for tonight. She is my attending. She is working with me together since more than 3 years. I know her since 4 years, and she is expert in endoscopic spine surgery. Together, we started a couple of years ago this project to introduce this kind of service in our spine service. And immediately it was clear that she will perform us all. She's a very talented spine surgeon next to all this usual spine stuff. She really got an expertise in endoscopic spine surgery. And today, I'm very proud that she really is the most experienced female endoscopic spine surgeon in our country. And I would love to hand over the mic to Catrina Scherrer. Catrina, I'm so glad that you said yes to show us some cases you've done, to show us some principles you've implemented. And please, Catrina, thank you very much that you said yes. And if you want, please start with your presentation.
Well, thank you for the kind invitation and kind introduction as well. And of course, to everybody else who probably hasn't heard of me yet, thank you for having me. It's a great pleasure that I can join you for tonight and show some cases. I did most of them together with Alexander and some maybe on my own, but we had quite a lot, especially in the beginning, a lot of those cases we did together. If you have any questions, probably just interrupt, or maybe I can talk a little bit with Alexander for a few details if he has something to add. Please also just feel free to interrupt me. I will just start if that's okay. My first case, I had some case presentation. Yeah, so I just start with the cases. First was a 43 female, not high BMI, so for the endoscopic, not only don't have to be endoscopic, but it's still nice to have a small scar. So she came in with back pain and had the radicular pain since only 2 weeks, radiating along S1. No motor, but the sensory deficit, and she was immobilized. She was on the ER, and we had to admit her and do an emergency MRI because we couldn't move at all. I have here the MRI, which showed a large hernia L5S1 on the left side, according to the symptoms, which was an S1 radiculopathy. We usually do X-rays, standing X-rays, especially for endoscopic cases, or if I think I want to do an endoscopic case, to be sure that the window 5S1 or L45 is big enough so we won't have any problems to get into the spinal canal. We discussed with her what to do, and we decided to go for surgery, I guess probably the next day, because the pain was just not bearable for her. This is kind of the short setup, how we introduce the dilator and go in with the camera. You can see here on the left side the camera already introduced, and here is just the dilator, and where we can see again the big window on the right side. It was easy in this case to get in. And here some pictures just to know on which level we get in, so where we have to cut the ligamentum flavum. Here already we're in the middle of surgery. I already cut some of the ligamentum flavum in this side. You can see here already spinal canal and some nerve structures. Here is still some ligamentum flavum. I have the video here where you can see moving from the fat tissue, and I still remove some of the ligamentum flavum to get a little bit more space to introduce now the trocar. The trocar is about 8 millimeters wide, so it's not a lot of space, and I don't need to open up the flavum that big to get into the spinal canal. We already can see the big hernia, which is down here. And we usually do, if there's enough space, a so-called turning maneuver to move a little bit the nerves away from my working cannula, so I can open up the disc herniation. Here, a really nice video where you can see how the hernia pops out, and it's actually just wants to get out because there's a lot of pressure. And we do still nowadays not anymore that often this turning maneuver. That was one of the, I think in the first year when we did the surgery, so it was 2 years ago. Nowadays I don't do it that often anymore, but usually it pops out like this if it's a big hernia. Yeah, sorry. The next you can see how we remove the big pieces of this hernia, and it's a really nice satisfactory feeling, even if the pieces are a little bit smaller than in open surgery. Usually you have to take it out in a few pieces. Not often it comes out in one piece because it's just the cannula is not big enough to support it, and then we have to take out the whole camera with the hernia to get it out. In the end, I turned the trocar back, and we can see that the nerve moves now freely over this hole where the hernia was. And here is the axilla, and it all kindly, quite nicely moves along and is free now. Sorry. This case was nice. She was fine the next day, still had a little bit of sensitivity problem and had a TVT, unfortunately. Still, even though it was a small surgery, it maybe took 1.5 hours, but a few weeks post-operative, they found the TVT, and she had to be on anticoagulation 3 months post-op. Otherwise, she was doing fine in the post-op control, and didn't have any pain, any radicular pain anymore, and no relevant back pain either. Here, I just wanted to show you the last part, where actually the one I like the most. Just here, when you see the muscles coming back and they close up, and it's just the only little scar of 1 centimeter, which is in the end, and that makes my surgery a success, and I'm happy that the patient is doing fine. I don't know if that would be the first case, if you want to comment anything, have any questions, or if I just go on.
Catrina, if you have a friend who asks you what is the best case to start, what is my number one case, would you say that this kind of case is the perfect case to start with endoscopic spine surgery, or would you just recommend another pathology and another hernia would be better?
I think that I just try to go back to the MRI. I think this will be kind of a perfect start because it's L5S1, so the window usually is big enough. We don't have to take away any bone. We don't have to use the drill. As you've seen, I didn't do it in this case either. You have enough space, so it must be actually the perfect case to start with. Maybe it's a little bit on the big side, so I wouldn't recommend to start with a really big hernia. This was rather big, so that would be the only point I would say. Maybe that's not the perfect case, but it's a really good case to start with. Yeah, usually L5S1 with a big window. Also L4-5 is always good to do interlaminar approach. This is the best approach. I will show the other approach, the transforaminal, a bit later. This is from the beginning a little bit more difficult because you're not used to this view in the transforaminal approach, but the interlaminar L5S1 would be the perfect one.
Yeah, and now you showed us a nice video of removal of the herniated disc. In the chat box, Professor Baeza asked the question: do you go inside the disc as well? Do you coagulate on the posterior longitudinal ligament? Do you coagulate the annulus? How deep do you go in these kind of surgeries, or it's just sequester removal the job that has to be done?
if possible, I only do a sequestrectomy. That's not always possible. I think in this case, it was a young patient. I try not to go into the disc. And then sometimes you just get in and you take a bite or just take out whatever is loose. But then I try to coagulate around the entry point and just tighten the longitudinal ligament a little bit, tighten the annulus a little bit, so that the recurrency rate is not that high. Yeah, I try this. I don't have a rule how deep I go into the disc. Sometimes I just fall into the disc kind of and then take out whatever is loose. But otherwise, I try always not to do a nucleotomy if possible.
Yeah, and you from your feeling here, what is your rate of recurrent herniated disc? Is it the same? Is this less, or is this more often? What is your gut feeling? I know we cannot compare. We didn't have a done definite match control study, but from your experience.
Well, probably it's about the same. The problem is that I'm kind of biased. I have a lot of endoscopic patients or endoscopic surgery, so when I have recurrences, then they usually had an endoscopic surgery. So I think have the feeling that they have more often recurrences, but I think as at least my colleagues tell me, it's about the same. So around 7% at least in general, we have a recurrence rate. And at the moment, with all the cases we did, we are under 10% recurrence rate. So it's about 5 to 7%. So that would be about accurate, I think.
Okay, thank you very much. You have another case?
Yeah, sure. I have another interlaminar case, which was a bit special, especially because it was a cranially sequestrated disc hernia, and the patient came in with a relevant motor deficit, so he couldn't lift his leg anymore. He had some problems with the back for years before, and then the acute radicular pain on the left side, and he had multiple falls because of it. He was also admitted emergently, and he had a disc herniation, L4 of F5, on the left side, sequestrated cranially, pressing on the L4 nerve. And we decided to go for surgery the same evening. So everything really quick, and we also decided to do it interlaminar because he had quite a big window. Here you can see the L4-5 window, which was big enough to probably get the trocar in. Then here I have a video where we are already removed quite a lot of the flavum, and we are in the spinal canal, and I move with the dissector here. I move the nerves the nerve root a little bit to the side, and then I can do this turning maneuver and move the nerve root a little bit further. Here I just turned back, and you could see here how the nerve just goes behind the trocar. And then I touch here on the disc or the part of the disc herniation. This is on level of the disc. Actually, there he had also a bit of a hernia, which we could feel, but it wasn't open. It didn't pop out. We did then in a second stage actually open up a little bit this hernia, took it out, but then underneath here under the L4 root, we could see this fragment or this sequester. We couldn't reach it with a hook. And I don't know if you remember, Alexander, you were with me there, and we really had to push the cannula so that we could reach up there because the L4 lamina pushed against us. But in the end, we could just grab it and take it out, and it was really nice because afterwards you can see how far up until probably the L4 pedicle you can see up here, and it's all free, so that we were sure that it is gone. In the end, I turn back the endoscope, and you can also see how the disc, the dura pops out, and it's free again. But the problem was further up, L4-5 cranially sequestrated. I think that's a really nice case. I still like to remember it because the patient did really well. Day after, he was definitely better with the quadriceps. He could walk again, and 6 weeks after, he was actually fine. He didn't have any pain, and the low back pain he had for years, he told me now it's finally gone. He was really happy about it. The quadriceps kind of recovered fully, and he wanted to start to work 6 weeks after as a mechanic, so really demanding job as well. And 10 weeks after, I wanted to see him again because of the motorics deficit, and he was fine. He said he didn't want to come back because he didn't have any problem. And that was 2 years ago now, and I haven't heard from him yet anymore. So I'm quite happy about this case. Any
Oh,
thoughts?
thank
Maybe
you.
Alexander, you remember him as
Yeah,
well.
yeah. I'm getting quite old. I can't remember, to be honest, exactly. But can you just explain this turning maneuver? Because you have got an asymmetric trocar and you're
Yeah.
pushing the nerve root to the medial side. Is there do you think it's a risk to injure the nerve, the transversing nerve root in this moment, or do you think it's just a safe procedure? This maneuver is always safe. Nothing can happen.
No, it's definitely not always safe. You have to have enough space to the lateral side. You have to be able to move the dura or the nerve root to the middle with this dissector. I always test this first. If there is a big hernia just there on the level of the disc, for example, then you would probably usually can't do it. There are often vessels going there, little scar tissue sometimes, and you have to be able to remove it first before you can do it. And then
Yeah. Can you
it's pardon me?
can you go one slide back and
Yeah,
show the video again while you're explaining
maybe.
this?
Yeah, sure. Sorry. So here I'm turning. So I was sure that I can move it, and I help with the dissector to move it to the medial side. And as I said, I always turn back a little bit and see the nerve again, and then I'm sure it's behind my trocar. Once I'm here, it's pretty safe, but I have to be sure that my trocar, which I said is 8 millimeters, has enough space in the spinal canal. If the spinal canal is just narrow because of the hernia or just because the patient is built that way, you shouldn't do the turning maneuver. Either you don't do it at all and still just work from outside the canal, grab underneath the dura or the nerve root with a hook or with a rongeur, or you do the different way and go transforaminally, which is the maybe sometimes safer way to remove it. Also in this case, nowadays, because I got a lot more savvy in the transforaminal approach, I probably would do this case transforaminally and not interlaminar anymore, just because I'm easy, I get there more easily. But there you have to be careful not to press too much on the nerve, and that you have enough space. If you don't have enough space, you always can take the um, a let's say a drill, and just drill a little bit on the side, the lateral side, and then you have enough space um, for the
Yeah.
trocar to turn.
Did you resect any part of the joint in this case, or
In
is it
this
just
case, no,
so
no.
it's just flavectomy and taking out the herniation without drilling parts of the inferior arterial process, without taking away the lamina, the upper lamina. It's just pure transflaval approach.
Yeah, here I think because I said before, the lamino L4 was quite pushy, and I think we did take a little bit away from the lamina, just with the stance, and just little parts, didn't use the drill, and nothing from the joint. No,
Yeah, and
it was just
when you target the height, you're not looking for a joint. Your just orientation is where's the flavum, where's the yellow ligament, which appears yellow in the
yeah.
endoscope, and then you're going make your access through the ligamentum flavum.
Yeah, I usually want to palpate the joint, just to then know how far or how medial I open the flavum, because you should go rather medial. So I try to have some distance to the joint, but I just palpate it. I don't open it up. I don't cut in it. And then I open the flavum, and I open the flavum in the middle, and then I take piece by piece towards lateral. I open it up with scissors or also a punch. And when I touch bone in the lateral part, and I know I'm lateral enough.
When I see this video, it's always good for a presentation. It's always this clear, or do you have sometimes problems with bleeders and it's more red than, because this is absolutely clear. It's like there
Yeah.
was no circulation at all.
Well, as you know me, I always chase the the erythrocytes, and usually it's not bleeding that badly. It can happen that you cut a vessel and then it's just blurry and you don't see it, so-called red out, that you can't see anything at all. Usually you find the bleeder, you can coagulate it, and you're fine. I had sometimes problems with it that I really couldn't see, and I had longer OR times because of it. But usually, especially if a patient is not under aspirin or under anticoagulation, there's not much of a problem with the bleeding.
And may I ask what kind of difficulty grade would this case be? Is this a beginner case, or do you have to have some kind of experience?
I wouldn't say it's a beginner case because it's cranially sequestrated. So that was really not easy to catch this little fragment, which was the main problem of the patient. The problem was not on the disc level. So I think this was a bit more advanced, a more advanced case. If it's on the disc level, it's easy. Also, this case L4 or 5, I think the window was big enough, but because it was upward herniated, yeah, that was more difficult. I wouldn't
And
recommend to start.
again, to highlight what you said, today you would go more likely a transforaminal
Yeah.
approach and not interlaminar approach because of why?
I think you're there quicker. It just goes easy. I can go in. I'll show you the cases afterwards. Turn, and I will find the hernia quite quickly. Then the second part, often it's just a little bit safer. As I said, with this turning maneuver, it can be tricky, and so I prefer to go transforaminal if I can. And just a preference, probably.
Yeah, it is. And
But
what about me? Would I have done is this yesterday transforaminal or translaminar? You know me. What was my preference?
I think you would have gone again interlaminar.
Yeah, and this is
Am I
so
right?
interesting. Yeah, this is so interesting because I did so many herniated disc with a microscope in a classic way, interlaminar fenestration, and still I'm struggling a little bit to go transforaminal. And this is what I just want to mention because if you're biased, you stick to your old rituals, and it's just I do it because I feel a little bit more comfortable with the interlaminar approach. But I have to admit that you are a lot safer and faster with the transforaminal approach, and still I'm beyond my learning curve. I look where you are, and I want to get there too. So I'm
We will
looking forward
soon.
to see the next case.
Sure. So we go over to the transforaminal cases, which was a 58-year-old male. He was a little bit on the heavy side, and we had done a decompression already by portal endoscopic L5, L4-5. Because of a cyst where he had there, and so the joint was already not that good anymore. And he was really doing fine after that. He didn't have any pain anymore 2 months after in the outpatient clinic. And then 3 months after surgery, he called me and said he has massive pain, radiculopathy, L4 downwards the whole leg, and he had no motor but sensory deficit. I asked him if he want to do another infiltration, if he want to try to get over it, because I assumed it was another disc herniation. But he told me no, he wants a definitive solution. He wants to go back to work. He just started working a few weeks ago, and now he didn't want to try again in a conservative way. That was his MRI. So you see in this, actually the decompression was probably all right. It's a little bit higher up, so the decompression didn't go up here, but that was fine. So it wasn't an L5 symptomatic anymore. But the L4 root had now a fresh hernia, where you can see here L4 on the left side is compressed in the foramen. I knew it was very fresh, and it looked in the MRI fresh as well. Here again, the X-ray, you can see our approach here for the decompression, where we took away some of the lamina. And in the transforaminal cases, I also want to check the iliac crest, because if the iliac crest is too high, it's just difficult to get to the foramen. If it's really up here, I probably would suggest not to do it, but still you can reach it if you use the drill. But the general rule is that it's okay until the upper pedicle, but further up it shouldn't go. So to reach L5S1 here, it would be already a little bit difficult. Now, when I prepare the transforaminal approaches, there's always also a little bit different, I think, from Alexander. I always plan it on the MRI. I want to know where my approach is, and I do a lot of measurements, and then I decide on how far lateral I want to go, where I have the entry point. I don't stick to it 100%. It's just an estimate, and then I check on the X-ray intraoperatively again where about I'm going to go in. But usually, until now, it was accurate. So here I would go around maybe 9 to 10 centimeters lateral, and then I would know to reach this point where the hernia is. And this I always measure on the disc level, not on the hernia level, of course, but I know where the hernia is. By the way, here you can see the joint and our decompression quite well. This was fine, but the joint is still already quite degenerated. Oh, sorry. I can't. Somebody's talking. Okay, sorry. So here I have the first video when I had the approach just getting in. I always want to have this triangle on the here, the cabin triangle actually where I go in, but I want to kind of clean this area, and down here would be the pedicle L5. Up here is the SAP, so the superior articular process, and I want to see the OS structure. And down here, you already could see in the video, when I clear it, here is the disc actually. I don't open it up, I just clean this area a little bit, and I want to touch the pedicle, the SAP, and then I know I'm safe. I know that the nerve exciting nerve root will be up here. It's probably quite close. It's in this fat tissue. So I shouldn't push on it, but if I put my cannula, which is again 8 millimeters, I put it here and I have enough space, then I'm safe. If I don't have enough space, I take away some of the SAP as to get me some more space to put my instruments in. Here, after cleaning this, I didn't do any drilling because it was not needed. I just could turn my endoscope and look cranially. Up here we have our nerve root, the L4, and then I could already see here the disc herniation, freshly herniated disc material. Down here, this is the disc. I didn't open it from the question before. I don't do a nucleotomy if not needed. I just take out the hernia, which is up here. Sometimes it's difficult to reach with the rongeurs, and I often use the coagulation instrument to just mobilize the disc. We also have hooks where we can mobilize it, but I like the coagulation because if something bleeds, I just can react straight away. and so I don't have any problems with the bleeding. And like this, I can remove more and more of this disc material. And when I think I'm fine and everything is out, sorry, yes, then I can palpate underneath the nerve, which is up here, also with this electric pen. I can palpate pedicle L4, and I take an X-ray, and then I know I'm on the pedicle and nothing is in between the pedicle and the L4 nerve root. Everything is free, and I know I'm done with the surgery. This patient did extremely well. He was up less than an hour post-op. He was in his room and wanted to go home the same day, which I could allow him, unfortunately. And he was back to work 3 weeks after. The next checkup is actually after my holiday, so I don't know how he he does, but I haven't heard since, so I assume that he's doing fine.
Catrina,
Yeah.
this is nice. Discharged several hours post-op, like this is an outpatient surgery. This is really nice. May I ask you to go one picture back and tell me what is the value of X-ray in endoscopic spine surgery if you go transforaminal? Do you really need it because you can have excellent visualization? Why the X-ray?
Well, because for the approach are always needed, because I go in blindly and I have to reach this point. I have afterwards the X-rays coming up in the next case, and I want to reach this point as I showed you in the first video here, where I see the pedicle and the SAP, and I can't find this without the X-ray. That's just not possible. So I usually go in first in the AP view, true AP, and then I change to lateral. Then I can change a little bit if needed. Maybe I use again an X-ray AP, but usually I'm on the right spot, and then I can introduce my instruments, and then I don't need it anymore. Once I see this the Camin triangle with the SAP and the pedicle, then I kind of don't need the X-ray anymore. But for these cases, to know where I am and to be sure that I'm underneath the pedicle, because sometimes you think you're there and then you take an X-ray and it's not really the case. So that's always good to have a check, and I like to have the X-ray close, be able to take one if I need it.
So you're still in full lead. You're wearing your thyroid protection. You're in full lead,
Yeah.
like a knight, like a warrior, and you're doing true minimal invasive surgery. So you pay the price of using a lot of X-ray, but the patient has got the less invasive approach.
Yeah. I think a lot of X-ray is a bit too much. I mean, if possible, I take maybe 5, 6 images. Um, I think for transforaminal, you can't be without X-ray. For the interlaminar cases, it would be possible to take one for the approach, and once you're there, maybe one to be sure that you're on the right segment, and then you don't need it anymore. So there is maybe 2 X-rays are enough. And the transforaminal, yeah, I think you should have it just to be sure. Also, when you're in the foramen.
Yeah, when the Camden triangle is described to be a safe triangle, do you agree that it's a safe triangle? You can always access the segment via the Camden triangle, or sometimes there is the nerve root in the way.
Yeah.
Nobody wants to hit the ganglion in the foramen because the pain is neuropathic then for a long time. Can you just tell us? Is the Camden triangle worth to be mentioned every time, or is it just, oh, yes, but don't be too sure. Don't rely on this. You need a proper visualization and don't go there in blindly.
Yeah, definitely. I would say this later is true. So be careful. I think for a needle, there's enough space there. Usually you get in the needle, but I mean, it's not a needle you put in an 8 mm troker, and there is not enough space sometimes. So first I check on the MRI. I really want to know if there is enough space. Is the nerve root just underneath the SAP? And I have to maybe drill a little bit the SAP before I go in, or is there enough space? Or as I assume there's enough space, sometimes they're still really close, and you'll be surprised how close the nerve actually is. Just turn around and the nerve is just straight next to your trocar. That happened to me quite a few times, and so I think you have to be careful. It's not big enough always. Sometimes it's really big enough, especially if you're higher up in L2-3 or L3-4 maybe, but down here L4-5, I wouldn't be sure. And I'd rather go on the SAP, drill a little bit to get access and have a safe space to put my instrument, and then I look for the nerve. And when I'm sure the nerve is safe, then I can really move around. So no, it's not enough just to go in the Cambrian triangle.
And my last question is the time you would estimate this procedure takes you for an nearly extraforaminal hernia disc. What do you plan? Is this like a Wilts approach, like a tube, like a microdiscectomy, or is this less time today?
Well, today, I mean, I don't know how long it would take me to do a Wilts approach because I never did it. I always did endoscopic. So maybe a Wilts would take me hours. The endoscopic like this, I will plan 45 minutes to an hour. I think, yeah, sometimes I'm a little bit quicker, but that would be my range.
Okay, thank you very much. Catrina, you have a case number 4?
Yes. Case number 4, a little bit older patient, also on the heavier side, and she had claudicative pain in both legs and cold feet for 3 months. It was a rather sudden onset with cold feet, which she had when she was standing up, when she could it was kind of claudicative as well. So if she was bending her back, then the cold feet would go away. I did an angiology check because I thought that's maybe I want to be sure. But the only thing we did see was this hernia L2-3, which kind of blocked the whole spinal canal. And I thought that could be the problem of this lady. And we agreed to do surgery, agreed to do it minimally invasive. We also have the X-ray here. You see it's already quite degenerative spine. I didn't want to take away more stabilization, so I did also the endoscopic way. We said we're going to take out as much of the hernia as possible. Unfortunately, I don't have that many videos of this case, but I just wanted to show you this, the approach again. I planned, sorry, forgot about this. But we talked before about x-rays and how I plan to get into my area. Here, this needle is already a little bit too far in. Usually you should stop here in the medial pedicle line. I probably did an x-ray before, but it didn't save it. And this is already the second one when I turned back after the lateral check. Because here in the lateral side, you can see that I'm a little bit too lateral going in. So the needle is already in the disc, but I'm not far in yet. So probably I went in a little bit too steep, but it was okay because I knew I had to flatten my curve afterwards and then go into the spinal canal. Oops, that was too quick. Sorry about that. So then I put in this little wire, and over the wire goes the dilator. With the dilator in place, I can put in my trocar. You can see already the camera inside. Through the camera, I have my working tube, working canal, where I put in again my electric probe. And this is actually the first x-ray I like to take because here I know I have the pedicle underneath me and the SAP on top. And then if I palpate this and I go in with my probe, I see it come around the pedicle, so I could go in the spinal canal here. Then I know I'm on the right spot. I have all my landmarks, and from there I can start my work. So this actually, I usually take this when I'm in, and after that I don't need any X-rays anymore. It's too quickly. Here I also palpated the upper part and the lower vertebra to know where I have to work, because if you remember the MRI, you know it's just on the level, the disc level. So I just have to take away all the hernia on this level. And then I work my way through to the other side. I take out all the hernia, and you see how I slowly progress to the other side until I can open up the rongeur. And also again with the probe, I go underneath the dural sac until I nearly to the other side. And when I reach here, I know I have freed the neural structures, and the hernia is mostly gone. Maybe I missed some parts, but not the important ones. Here, the last picture where I see to the other side. Up here we have the dura, maybe starting L3 nerve root up down here, and underneath you can see it's a big hole. There's everything, all the disc material is out. I probably went into the disc here, but I mean, this lady didn't have much disc left anyway, so I wasn't too cautious here to not do an oculotomy. I took out everything which could come back. So yeah, she was happy. Cold feet were gone in the first night, and we still also her. I haven't seen her yet back at the ward. Yeah, she was doing fine, didn't have much back pain, and was discharged the second day after surgery.
So this is a nice case, Catrina. Thank you very much. May I just ask you to go to the MRI, to the pre-op MRI with the huge hernia, because I think this is a perfect case. This is not an easy surgery. When you would do it open, you have to face big facets. I would do it from the left side. Probably the hernia looks a little bit more on the left side than on the right side. But the mobilizing the thecal sac to the medium or to the contralateral side, you can clearly see that the caudal equiner is compressed severely. And I think these are the dangerous hernia discs when the surgery can make it worse. And the transforaminal approach is pretty nice because you don't have to mobilize the thecal sac. Do you see the amount of back pain as a limitation for endoscopy, or would you recommend a non-fusion surgery at first sight in every case? What is the clinical finding when the patient has not only leg pain, but also severe back pain? What is the value of endoscopic decompression?
I mean, you still can decide or discuss with the patient to try take out the hernia. But I mean, if you see big effusions in the joints and you really see a shifting in the X-ray, then I think you have to discuss with the patients to do a fusion surgery. But I mean, this lady, she was already 70. I know it's not that old, but still, she was yeah, otherwise rather a bit older, and had some other issue as well medically. So she didn't have any back pain before, so I didn't discuss it with her to do a fusion surgery here. But I mean, you see, she doesn't have much disc left, and there is also some osteochondrosis here. So yeah, other cases where there's a lot of back pain, I would discuss it, but you can also just try to take it out and see if it helps. And then second to that, you can do a lateral approach, for example, and you have no problem with the nerve compression, and just to the minimal invasive stabilization for a second surgery. I think that would be a good case here if she really has back pain afterwards.
Oh, thank you very much, Catrina. You have another case. We have got some minutes left.
If you like, I have one left, but
Yes, of
up to
course.
you.
Please, please.
Yeah, that was a really young patient, and she had I've known her for 2 years. She had a regular radiculopathy of L5, and did respond to infiltration. Then she had her second child, and then it got worse and worse. When I met her, she had really bad pain already for a year, and getting worse the few months before. She was limited of energy because of analgesia, because she was breastfeeding, and she decided, because the hernia was actually enlarging over time, that we should go for surgery. That was the newest MRI I had, with a big hernia L4-5, compressing on the L5 nerve root. And we decided, or we talked also about the endoscopic route, especially because it was a young patient. I didn't want to cause too much damage on the joints. Here you can see the X-ray. I mean, L5 as one, that would be a huge window. You could easily do an endoscopic interlaminar approach, but L4-5 was rather small, and the approach transforaminal was just the best route for what I thought, and I decided to go from transforaminally because the access was easy. There's a really low iliac crest. Here my MRI, my calculations before, you can maybe see that my calculation would be that I go through the joint. I was prepared to take a little bit of this joint away. I had a drill with me because I knew I need to go nearly to the middle of the disc. So I need to take a little bit of this joint to decompress the L5 nerve root completely. Here again, preparing of my Campbell's triangle. Actually, here I have my pedicle down here and the SAP up. Then I will put in the electric probe through this hole where the foramen is, and if I'm in the spinal canal, I know where I have to work. Oh, sorry, I was on the right side. Down here is the pedicle. I can't see. Sorry, that was my mistake. What you also can see here.
Catrina,
Yes, sorry.
may I interrupt? Can you restart the video and comment of what are you cutting through?
Oh,
What are
sorry.
these
Yeah.
structures? This is very interesting.
These are vessels. There's always a lot of bigger vessels. I coagulated them before, and then I cut them. In the foramen, usually you find 1 to 5, up to 5 big vessels. And if you don't coagulate them properly, then it will bleed. And that's one of those which you can look for a long time, and then you can't see anything, and you have a real good red out. Not usually you can help it, but it's quite annoying. What I wanted to point out here, that you see the blue, I put in methylene blue here in the disc. That is sometimes when I just want to have a better distinction of the tissue, then I put into my needle, I put some methylene blue. And so I have a good distinction, what is disc and what is hernia. The hernia usually gets really nicely blue, and if I pull on it, I know I don't have a nerve in my rongeur, but it's hernia if it's blue. So that's quite a good trick. When I'm that far here, then I take out my drills. Here I have a normal drill and a diamond drill. We also have a so-called tip control drill, which you will see here in the next video, where I can move a little bit the tip and go around the corners. This is quite helpful, especially in these cases, in the transforaminal cases. I sometimes use it. Not that often. When I started the drill, I used it quite a lot because it was, yeah, easier to get to the places. But nowadays, I usually use only the straight drills. Here you can see the ligamentum flavum. So I drilled away a little bit here of the SAP, the superior articular process. Down here we have the pedicle L5, and then the disc space around here, and you actually can see the beginning of the disc herniation here. And then I just did a little turn of the trocar, and you can see that the nerve root, the L4 nerve root here, is just next to my trocar. So it's really close. This is my only space I can work. I shouldn't press upwards because then I press on L4. I shouldn't press outwards because then I can compress the L4 nerve root here, because the nerve, my trocar is beveled. I can push a little bit away, but I shouldn't push too much pressure on it. And I had to learn to speak a lot to the anesthesiologist, because when they tell me, oh, the patient is tachycardic, they have tachycardia or a high blood pressure, then I know I'm too close to the nerve, and I let go of the pressure a little bit, and usually they tell me it's fine again. So I don't accept anymore if they put in more and more analgesia or propofol. They should really tell me, because that's the main indicator that I'm too close to the nerve. Here you can see me then take away the ligamentum flavum with a punch. That's the last part, also the last part of the bone I usually take away with the punch, because it's just safer, so I don't hurt any neural structures on the other side, because just around here is the entry to the spinal canal, which you can see now when I prepare this bump. You can really see here, I can't get underneath this ligamentum flavum because of the big disc herniation which is just in front of us. We can't see inside the canal yet, but if I take out some of the hernia, and I found a little bit by chance here, I found the entry in the disc herniation, and I could take out big pieces. And when I the next piece, I think, yeah, you can see inside the canal and see that it's beginning to be free, but there was a lot of disc material be taken out here. Yeah, that's nice. But it was not only one of those, there were about 3 such pieces, and then the smaller ones. And now you can see even a little bit of neurostructures. I took away afterwards all these ligamentum flavum. Before, it was not really possible to reach underneath. And when I took away some of the hernia, then I could suddenly see more and take away. And in the end, you could see the nerve root passing by and pulsating freely. That's the main goal I want to achieve. In the end, it should always be pulsating. And when it's doing this, then I'm fine. Then I know it's I freed it enough. Still a bit blue down here. This is probably in the disc, in the yeah, the remaining disc. I don't take out all the blue. It goes away. I had to check once. Somebody told me it stays in for months, but that's not true, because I had to do a recurrent disc hernia, and there the blue was gone after not even 2 months. So probably gets the body just removes it after a while. She was doing fine. I was obviously manipulating a little bit L5. She had a bit of a slight weakness the day afterwards, but she could be discharged the second day after surgery, and the L5 nerve was yeah, doing fine. She had a little bit of a foot slight weakness in her foot, but otherwise it was fine. Yeah.
Oh, thank you very much, Catrina. This is impressive. When I do a microdiscectomy, you can call me in the night, and I don't even need an X-ray. Usually, MRI is enough, and I think it's quite interesting that you really showed us what you have to measure. So planning for endoscopic surgery takes some more brain work pre-op and intra-op than a classic interlaminar fenestration. So when we talk about a workhorse, something you do quite very often, I think it's clear that the endoscopic spine surgery is a little bit sophisticated in the beginning. Maybe in 5 years you won't do this planning. You go there by freehand gut feeling, and you will be immediately where you have to be. But in my impression, it is more like these videos we see from parachutes, people jumping from a plane and landing on a point as predicted. So would you agree that the Camden triangle is more a Camden point, that you have to be exactly on one point, not a huge area, not the whole stadium is allowed. It's really going to a point, and then from this point you are approaching to the neural structures, and this is it's a better description of what the difficulty in the beginning is.
Yeah, I would agree. As I said before, a needle usually is fine, but more is just too much. So I would agree you have to plan it, but I heard of many other colleagues as well, they don't do this planning as I do. I'm quite strict with myself. I just want to be sure and look at it again and again. But that's maybe just my, how I am. But the Camin triangle is definitely not a big area, as I showed you in the picture here before. I mean, I'm right in the Camin triangle here. So, I mean, here already I have taken away all the bone, but still the nerve is just around the corner. And if I don't take away this bone and don't make a little bit of space, then I'm just pressing on the nerve. Or if the nerve is maybe not in the normal position, but a little bit displaced because of a disc herniation, then you can just hit it quite easily if you don't know where it is, or if you don't take away a little bit of this space. So I think this picture shows how close the structures are, and you have to be prepared for this. And as I said, with these little tricks with blood pressure as well, just to listen. And if something changes, think about it. Maybe you're too close and you shouldn't go on, but just change a little bit your trajectory or your pressure, and then the patient is doing fine. I mean, that would be one reason why I would like to do, or would be great to do it without just in local anesthesia, because then patient could tell you and you would definitely not have this problem. But I think in our case or in our hospital, that's not an option at the moment.
Oh, thank you very much. Katrina, I just have to say something because I relied a little bit too much of my anatomic knowledge and experience in the transforaminal approach. And what I learned from you is that making this list, this exact planning step by step, and stick to the rule that you do it quite like an algorithm, this really boosts up the complete surgery, and you're not wasting time on the left, on the right, up and down, but it's going very strict, not discussing what to do next, just drilling down the SAP, just going there using methylene glue in every case. This is so so if you stick to the rules of Catrina Scherrer, it's really a good approach. It's a safe approach, and you will boost up your speed, your OR time. Thank you very much, Catrina Scherrer, for showing us these impressive cases. It looks so easy, and I know you're approaching the 200 cases experience, which is extraordinary. If you go on the national view here in Switzerland, it looks so smooth and looks so beautiful, but it's hard work. It's hard brain work. It's a lot of planning. It's a lot of discussing. And I really appreciate what you have reached, and the next milestones will come. Thank you very
Thank you
much,
very much.
Catrina Scherrer. It was awesome. Thank you very much.
Thank you very much for having me.
Next week, I guess well, it will be announced on social media. Just stay tuned, and thank you very much. Wherever you are, I've seen people from all around the world, from Saudi Arabia, from so many countries. Thank you very much for joining us, and I wish you all a nice time and have a good night. Goodbye.